this session is about familial hypercholesterolaemia and is one of a series that we've been running. And as part of evolving that series, we have listened to the feedback that you've given us. So do please continue to do that for us. We're very grateful for any feedback that we can get, because it does shape future thinking. We've had sessions, and I think there is an increasing awareness of FH, and this session's looking at the understanding and wider aspects with regards to familial hypercholesterolaemia. So we'll move straight on to our two speakers who are going to, I'm supposed to tell you that we're now Health Innovation Network. Many of you will recall we were the Academic Health Science Network, and we've now been redesignated as the Health Innovation Network. But what we do, all our visions, etc., are just the same as they have been. Next slide, please. Right, we have two excellent speakers. They're going to do a double act. Stuart Patman is a consultant chemical pathologist and lead for the lipid service in Northumbria Healthcare Trust. And Catherine Tucker is a senior clinical pharmacist in the lipid clinic, again in Northumbria. She's a cardiovascular disease medicine optimization pharmacist with the CVD prevention network in the Northeast North Cumbria. And has a range of experience working in both primary and secondary care and in cardiac units and other aspects with regards to lipid management. So I think we'll move straight on and ask them to take over. Thank you, Stuart and Catherine.
Thanks, thanks Jane, and thanks everyone for joining us today. So as Jane mentioned, we're going to cover the topic of familial hypercholesterolaemia between myself and Catherine, and I'm going to start a little bit just by giving a brief bit of context about what is familial hypercholesterolaemia. And I think a lot of you will have heard of this, a lot of you will be familiar with some of these, but emphasize some of the key points in terms of the condition. But also to give you some practical pointers in terms of how in your day-to-day work it will help you go about identifying these sorts of patients. I'll also then just touch on what the lipid clinic can add, or what your patients may expect when they are referred to the lipid clinic as well. So just in terms of FH, I think some key pointers here just to emphasize. So we've got the condition is genetic. It's an autosomal dominant condition, and I think the key point of that is that family history is very important. So if you find that there is an affected someone in the family who's affected by this condition or has high cholesterol or early heart disease, that is a marker, that is a flag to think about measuring lipids in the rest of the family because of this dominant inheritance pattern. In terms of how common it is, I mean, there was a traditional thought that this was about 1 in 500. I think we've refined this a bit more in terms of its prevalence. It's more thought to be about 1 in 250 nowadays. And here's a picture of St James's Park, and there's about, I think the current capacity is around 52,000 of people in St James's Park. So you will find if you fill that with people, then you get 208 people would have FH statistically on that 1 in 250. So it's not the easiest thing in terms of identification, but type 1 diabetes is probably a similar sort of prevalence. So it's not, we're not looking for needles in haystacks in terms of rare diseases, but it's one that you're probably in terms of your population size, you can then scale that down to your list size to see how many you might have in your practice statistically. And the key thing clinically is it doubles your cholesterol in essence, and that really accelerates any atherosclerotic process leading to early or premature vascular disease. Is a clinical context in terms of what we're trying to identify and reduce and mitigate the risk of. Thanks. Next slide. So in terms of the context, national drivers, and I think Catherine will touch on this a little bit later on, but there's been a nice guideline since 2008 around familial hypercholesterolaemia. this was accentuated a little bit more recently in the long-term plan, which came out just pre-COVID in 2019, which actually had the aim of identifying 25% of FH cases. Given this 1 in 250 prevalence, we need to identify more cases of FH, and this was one of the long-term plans to do in the next 5 years. So actually coming up to that time period now in terms of an aim of getting 25% of the case identified. More recently, QOF has now reflected some of the importance of cholesterol. That they haven't explicitly mentioned FH, but they've mentioned around targeting people with secondary prevention around measuring cholesterol levels and aiming for targets. So we're probably measuring, or a bit of spotlight on cholesterol, and looking at this a bit more, measuring this more regularly in the context of these QOF targets. Next slide. Thanks. So how are we doing? We mentioned that 25% targets, and this is nationally. This is data from the NEQOS service, and thanks to Kate Thurland and colleagues who have allowed us to share this. It's a bit of a busy slide, but I think the key percentages are the ones in this blue line here, that in up until the last sort of financial year, just a couple of months ago, we were getting up to about nearly 13% of patients identified in the within the ICB boundaries. This has crept up really over the last few years, and we can see that on an annual basis, just to show some of the numbers of patients that are being if you like, identified 67 positive cases in the last year. There's 293 negative. These are patients who we think may have FH, but when they're tested, we don't find a variant present. But we are detecting each year a further number of cases within the ICB boundary. And this shows there's also relative. So through cascade testing, when we identify an individual who does have the variant, first degree relatives are then offered the test, and this shows that you do get a yield of positive relatives detected, and obviously negative relatives. You probably expect about 50-50 in terms of those, if it's an autosomal dominant condition. For reference here, we always know that Northern Ireland has a very high pickup rate, that they have, for various reasons, they've always had a high pickup rate there, near 21%. Wales, they're slightly higher at 12%, and Scotland at 10%. These figures are slightly old as well, but just gives some contextual feeling to that. So we're doing well. The figures are increasing, and we're perhaps a bit optimistic to reach that 25% pickup rate. But this part of these this education and what we're showing today is hoping to increase this figure as we go up. Next slide. Thanks. So just before I hand over to Catherine, just setting the scene. So I think a lot of you will be faced with blood test results. I think that's probably the first key really to identifying these patients. It's not that the condition manifests itself by someone saying, look, I think I've woke up in the morning feeling like I've got FH. That sometimes comes out if patients' relatives have been tested, but it's really cholesterol results that are going to be the mainstay of identifying these patients. And we'll touch on this a little bit later, but the Neely guidelines are another facet in terms of what we discuss here. Is linked really with Neely and the pathway that's linked in that sort of salmon color pinky section of the guidelines is the one I would direct you to in terms of identifying these patients. So I'll hand over to Catherine with a bit more sort of practical aspects now of identification. Thanks.
Thanks, Stuart. Next slide, please. So the key document that we use to help us with identification and actually management of patients with FH is the NICE guideline, as Stuart mentioned. It was updated in October 2019, but the key messages are still very pertinent. Next slide, please. Part of the first thing that we need to do is actually identify the patients, and one of the ways that we can do this is by using digital searches within the clinical record. There's lots of searches available. There's UCL Partners, who are a group in London who've got a great website. There's Arden searches, which many of you may have used for the QOF targets or for the DES-IIF targets. However, our local group is the Clinical Digital Resource Collaborative, and that's a group of North East clinicians, which is led by Gareth Forbes, who's a GP in Durham, and I think Gareth might be with us today on the call. But this is a really great resource, and these are the searches that we've used in our work in Northumbria. Next slide, please. So I've put the website address on this slide. If you've not had an opportunity to look at the CDRC resources, I can really recommend them. Gareth has actually done some video recordings as well for Health Innovation, which are available on the Health Innovation website, which go into details of how to actually use these within your clinical systems, so both in System 1 and EMIS. And Gareth and the team have created a visualization dashboard, which actually gives you a great overview of what's happening within your practice for certain clinical conditions. And today, obviously, we're focusing on FH. And so the CDRC website actually talks you through the different searches that are available. I don't know if you've managed to use the CDRC searches, but sometimes when you open them up, they can be a bit overwhelming. There's lots of lines of searches and it can be difficult to know where to start. But the website actually talks you through that and tells you, which bit of information you need and where to start. So an example I've used here on the right-hand side is an example of searches based in a PCN of 50,000. The first search to run is 2.0, which tells you in your practice, these are the people who you should consider for FH. And in this example, the search returned 321 patients, which is obviously quite a large number to deal with. Another search then to break down that number and to focus on or prioritise that group is 2.02, and that tells us who are the higher risk patients within that 300. And when we run that search, it came back as 77. So that's a bit more of a manageable number. The other search to highlight is for those who are coded with FH, but who haven't had a genetic test yet. So historically, we have identified patients with clinical FH and coded them with FH, but the genetic tests weren't as freely available. But now what we're asking people to do is actually revisit some of those who are coded for FH and make sure they've had a genetic test. And what this enables us to do is actually access other family members. We know that the cascade testing is much quicker and is actually cheaper and actually returns a higher rate of positive cases. So if we have got people that we know with FH, we need to be able to offer their families the genetic test as well. Next slide, please. So once you have your list of patients, it's really key to actually do a desktop review and go into the records and actually find out a bit more detail. Some patients have had previous interactions with the lipid clinic, and it's just a case of understanding where we're up to with them and what we need to do next. Some patients haven't had any interaction with the lipid clinic, and if that's the case, we need to dig out the Simon Broom criteria, which is in the Neely guideline, and you're looking for two bits of information. The first is, does this person have a total cholesterol greater than 7.5? And actually that can be a historical value. The patient might actually be on treatment now and they might be to target, but if they've had any cholesterol reading ever that's greater than 7.5, we can consider them for FH. The second piece of information, which isn't often recorded in the clinical record, is the family history. And in order to meet the Simon Broom criteria, we do need a bit of detail around this. So if you are speaking to patients, we encourage you to ask them, has anyone in your family had an MI less than 60 years of age, and who is that family member? Is it your parents? Is it your grandparents? Is it your sisters and brothers? But just to give us a bit more information on which we can base our assessment. Another thing to mention is actually it's important to exclude secondary causes. So if somebody's triglycerides are greater than 2.3, there's a good chance that the high cholesterol may be caused by a secondary cause. So it's important to consider somebody's diabetes. If they've got diabetes, can you optimize their diabetic medications? Has somebody got hypothyroidism, can you optimize that medication? often if people consume a lot of sugars or a lot of alcohol, that can also affect the triglycerides. So there's a bit of work to do there before referring them. But if you do have somebody who meets the Simon Broom criteria, please refer them to the lipid clinic. Next slide, please. Once they're in the lipid clinic, we make another assessment, and then we can take a blood sample, which we send to the Centre for Life. And the Centre for Life then analyses the DNA and sends back a detailed letter to the GP to go into the clinical record, and we get a copy in the lipid clinic. And then the genetic nurses can start the counselling process and initiate the cascade, the family cascade testing. One thing that we're trying to do from the lipid clinic is actually include some of the SNOMED codes for the diagnoses that we find. And this is to try and support primary care with the coding. We know that the digital searches rely on the coding, and the more accurate the coding is, then the better the searches that we return. And an example of this, which is something that we're thinking about for the future, is lipoprotein(a). So at the moment, we're starting to test more people for lipoprotein(a) levels. We're not asking everybody to test for lipoprotein(a). There's actually a very specific page within the Neely guideline which gives a lot of detail on the work that we're doing on lipoprotein(a). But for those that we do test and where we find a high lipoprotein(a), we're asking primary care to code this within the clinical record. And this is because although there isn't a treatment at the moment for lipoprotein(a), there is ongoing clinical trials, and it may be in the future that we need to identify this cohort of people so that we can offer them treatment to reduce those lipoprotein(a) levels. The key thing once we identify somebody with the FH gene is to support them with treatment, and this is a long-term treatment. Next slide, please. We base the treatment recommendations off the NHS England treatment pathway, which again is in the Neely document, and it's important to determine whether somebody requires primary prevention, which is on the left-hand side of the document there in the green coloration, or does somebody require secondary prevention, and that's in the red, on the right-hand side in the red coloration. For FH, there's a specific recommendation within that document for FH, which is the blue section. Could I have the next slide, please? So the targets for FH, if somebody has the FH gene and they require primary prevention, we're aiming to reduce their cholesterol by 50%. So we want to reduce their LDL or their non-HDL cholesterol by 50%. And there's lots of ways that we can do that. Again, this is all detailed in the NHS England treatment pathway. But we need to be thinking about, changing a statin if the statin isn't getting them to target or they're having side effects. We need to be thinking about adding in ezetimibe. And also now we have the newer medications such as the injectables. We've got bempedoic acid. We've even got Vascepa as well. So there's lots of different options that we've got. And the key is to reduce the cholesterol as much as possible. Next slide, please. So the NICE guideline for FH recommends that we do an annual review for patients who have FH. And this is really to keep a track on the cholesterol target and also support people with medication adherence. We know that generally speaking, medication adherence is difficult for people. There's some figures to suggest that 50% of people don't take medication as prescribed. I always find that figure quite shocking if you consider how much money we spend as a health system on medication and actually how much time we spend speaking to people about medication. But it's certainly something to think about and maybe reflect for each of us. How do we communicate those messages of supporting people to take medication? How do we support people to take the medication and reduce their cholesterol as much as possible? With the statins, as I've briefly mentioned, people do sometimes experience side effects, and it's important for us to explore that and try and determine what's, if it is the statin that's causing it. Again, in the Neely guideline, there's a sheet on statin intolerance, and that works through the different steps in the statin intolerance pathway to help us try and determine, is it the statin that's causing this side effect or is it something else? In identifying people with FH, there's a specific group that we need to think about, and that's the young female group who might be might be planning a family. And it's really important for us to have a plan for the statin for this group of patients. Statins are teratogenic, so it's really important that the statins are stopped 3 months before conception and not restarted until after the breastfeeding's finished. So it's just something else to think about. We know that this group of patients have got a high risk of cardiovascular disease, and so we need a low threshold for CVD investigations. So if somebody's reporting chest pain or shortness of breath, then we need to be investigating that. And the final thing for me to mention is just about lifestyle and diet. For FH patients, they are very high risk for cardiovascular disease, and medication is the first line. We know that the medication reduces the cholesterol very efficiently and actually very quickly. However, there are things that everybody can do with their diet and lifestyle. And it's really important for us as healthcare professionals to make sure that we make every contact count, and we take that opportunity to discuss the different things that people can try. So, you know, tell me a bit more about your diet. How do you feel about losing weight? How much alcohol are you drinking? Do you smoke? How much exercise are you doing? And something that I've found quite useful is to have a list of the local services that I can signpost people to. So there's different services available in different areas, and there's different ways that people can access these services. So, you know, everybody's different, everybody receives information in different ways, and everybody has a different preference for information. But for example, some of the stop smoking services, you can call into your local pharmacy and speak to somebody on a regular basis about it, or you can access the information on the telephone, or you can access it online, depending if if you're working or you're doing different shift patterns, that kind of thing. So it's really important to understand what services are out there and actually tailor that information for the patients that you're speaking to. I'm going to hand back over to Stuart.
Thanks, Catherine. Next slide, please. So just to think a little bit about the lipid clinic and a couple of thoughts, because I know we get some kind of choosing book requests saying that the patient was reluctant or maybe not seeing the benefit of coming to a clinic. So just to explain a little bit in terms of what you might want to say to the patients in terms of what is the benefits of coming to clinic. So we can assess the patient for genetic testing. Now, not all the patients who we would see would we automatically undertake genetic testing for. And the reasons for that is because really along the sort of phenotypes and what information we can get about the family and the strength of history. Now, essentially, we saw from some of the genetic testing figures earlier that the testing comes back with positive and negative results, and what we've gone through nationally as a process of trying to identify patients who have on a scoring system, and one of the ones that you may have heard of as the Dutch Lipid Clinic Network scoring, where you can actually build up a value, and the higher the value, the more likely you are to identify a genetic variant. And sometimes we just don't have a high enough value, and actually in those cases, often we may be treating them as if they've got FH, but we don't actually do the genetic testing at that point in time until sometimes we get more information, or actually sometimes we just treat the patient and say the genetic testing may not add to the benefit for the individual because they don't have, say they don't have a family, or they don't have children, or they don't have any relatives that they're in touch with as well. So genetic testing is one of the things that we can do. So setting the lipid target, and Catherine mentioned some of those things around the target, that 50% reduction for the bad cholesterol. And the other thing is just optimizing and sometimes accessing the medication. So that's the injectables, again, the PCSK9 inhibitors, which are a red drug, hospital only prescription. And we can train the individuals to self-administer those. And a lot of patients now have heard of injectable cholesterol drugs. So again, that's something we can address, and looking for those higher LDL cholesterols of those eligible patients. Next slide, please. So moving on just in terms of the kind of breaking down a little bit of that Neely guideline. So I'm just going to that sort of salmony pink section for the guideline. And this is kind of probably talking from about a practical point of view and some of the things that might add to the things you might want to be thinking about when you're going through this guideline. Everyone can read the guideline and see what it says, but it's just more about what we're kind of thinking from our experience might be quite useful to do, or the questions that we sometimes get asked. So I think the key thing is around the need for more than one lipid profile. So often there may just be a single lipid profile, and perhaps someone said, oh, it's very high, we'll just start you on statins. I would always encourage them to do a fasting lipid profile. You do get biological variability between measurements. You do get people who I don't know, have come back from an all-inclusive holiday and then just rumble in from that Monday morning blood test, and we get a slightly skewed picture. And I think sometimes having that gap between measuring a high cholesterol and people go away, oh, I need to just have a couple of weeks of just thinking about what the things that I'm doing slightly differently, especially with the diet in the shorter term, is the things that they want to change. But also it allows them to get that fasting measurement. That second one should be a fasting. And the reason for that is to try and get that LDL measurement, which is the one that gives the most accurate reflection of the LDL, which we use in the actual Dutch Lipid Clinic Network scoring to think about the need for genetic testing as well. So once you've done those two lipid profiles, another question I get asked is, should we start the patient on a statin? Because obviously there's a number of lipid clinics around the region. Personally speaking, we have got quite a long waiting list in Northumbria for new patients. That's obviously on our mind, but patients can be waiting for nearly up to sort of 10 to 12 months for new patient appointments in some circumstances. So then there's a consideration about, should you start the patient on statin? And actually, I would say, as long as you've done those two lipid profiles, especially had a fasting lipid profile, and you're thinking, well, actually, the cholesterol remains high, there isn't any harm in then, if the patient is happy to commence a statin at that point. What I wouldn't do is just do one lipid profile and then just suddenly start them on a statin. The other thing to think about if you are starting on the statin is, as Catherine mentioned, just around the lifestyle things, is just not neglect that. I know the time to speak to patients is vanishingly small these days, but actually talking about the lifestyle parts of it, thinking about what people do with the diet is very important in terms of assessing the whole picture and the whole approach that someone's taking to kind of risk prevention in the future as well. It's also important just to think about, just probably before you jump into the prescription pad, is to think about secondary causes. So, HbA1c is in there as a screen for diabetes. Think about diet. So if a number of patients who've adopted some of the keto diets and which can give very impressively high cholesterols, up to 9, I think we've seen for a cholesterol, where somebody has really moved to a kind of a low carb, high fat diet and really can put their cholesterols very, very high. So just sense checking what someone's doing. There's the Heart UK diet leaflet. I think that's on some of the referral platforms and something we share in cases with some referrers as well. That's a really good PDF. If you Google Heart UK diet PDF, then it comes up as one of the hits in that, and it's a very good leaflet in terms of color coding some of the food types that are beneficial and some of them to avoid as well. I've put, because it's always nice to have 3 Ds, I've put drugs as the third D, and that's medications really. So just making sure there's nothing on that. I suppose antipsychotics are some of the things that patients may be on a long-term medication for that can contribute to higher cholesterols in there as well. So it's just checking if there are any medications that are either short-term, and some things like acitretin and things like that can obviously sort of more familiarization of drugs, but they can give high cholesterols as well. The other one in terms of testing that sometimes gets missed out is this urine ACR. So very rarely you get nephrotic syndrome, but urine ACR is also a vascular risk marker. So if it's increased as well, then assessing things like blood pressure and assessing things like CKD is also important as well. What I would say is, if you see high triglycerides in your profile, and that's really triglycerides certainly above 4.5, then you should be looking at the yellow section of the NEALY guidelines, and that's probably more appropriate because the FH patients tend not always, but tend to have lower triglycerides on the whole. And if you get a higher triglyceride, you're best approaching it from that point of view, trying to deal with the triglycerides, because there might be a unifying issue with that, which is also increasing your cholesterol as well. So I direct you to the high triglycerides when the triglycerides are above 4.5, essentially. Next slide, please. The examination section is next in the flowchart, and I always say don't get too overwhelmed by the examination. I know obviously a lot of consultations are performed over the phone now, or we're looking at information on a computer screen, and you won't always have that information. So I would say family history is a crucial bit of information here. That family history of heart disease under the age of 60 is the key bit there in a first degree relative. It's talked about second degree relative under the age of 50, but it's really, if you know about first degree relative, that's the really key bit, because obviously the genes can't skip generations. They've got to go through first degree relatives. And also cholesterol above 7.5 in a first degree relative. A lot of family members, older ones, may be on statins. That doesn't always equate to having a cholesterol of 7.5. Sometimes that information is available, sometimes it's not. If we don't have the information, it's probably sensible, and we feedback often to get adults, family members, cholesterol checked prospectively to make sure that's not above 7.5. So that's brothers, siblings, whatever, sisters, whatever, adult children, to make sure that they're checked as well. So these are the key things. If we do find a first degree relative with the heart disease below the age of 60, cholesterol above 7.5, or the first degree relative has a genetic diagnosis of FH, those are the key ones that we would be accepting routinely into the clinic. But obviously we're happy for advice and guidance for any other ones where there's uncertainty. This information you don't know is put that advice and guidance in, and we can feedback in terms of what we think on the basis of that. I would say advice and guidance is probably the most flexible route, because we can have a narrative on our system. We can reply and say, that's what about X, what about Y? And you can reply to that, and we don't need to put a whole new referral in, which on Choose and Book, I think if we put a question back, it loses it from the system. So I always prefer advice and guidance in terms of that, having that dialogue where there may be questions that we come back with. Next slide, please. So we mentioned, and Catherine touched on the genetic testing there, just to say what happens if we find something, what happens if we don't. So I always say genetic testing is like looking for a spelling mistake in a book. So you're looking for a spelling mistake in a big book like the Bible or something. We do initial screen, and we look at the pages where we think we frequently get spelling mistakes, and we look for those variants, and they're usually ApoB, LDL, PCSK9. There's a number of others, but we look at those bits, and if we find a variant in there, then we can say, great, it's present in the index case. When you get a cascade, a relative of that person, you can just pick up the book and you can turn to that page and you say, look on that line, that word, is there a spelling mistake there? Yes or no? If it's there, yes, then they're positive. If it's there, not, then they don't have the variant. But it's much easier to do the genetic test in the relative once you know what the index of spelling mistake is, because you know what page and line, etc. you're looking for. So that's why we sometimes go back and say, just need more details about the first person who's been found to have this genetic test, because it really pinpoints where we can do that searching on the follow-up genetic test for the family members. So if we find there's a variant there, then that's obviously Centre for Life. That's the team who analysed that. That comes back with a genetic diagnosis. We aim to decrease the bad cholesterol by 50% from the peak. And they're also eligible for PCSK9 inhibitors should their LDL cholesterol be above 5, and we struggle to get it down with statins, etc. If they don't have the variant there, then we can't do the cascade testing. We can't do the testing in the first degree relatives. But what we can do is still advise them to get their cholesterol measured, because there's probably some genetic variants that we don't know out there that we've not yet determined. So I always recommend family members get their cholesterol checked. And if they're above 7.5, then we probably need to be careful with those relatives and potentially treat them. If it's not, then we can be more reassured. Even if we can't find something, if we've got a strong phenotype within the family and it fits, that then my process would be to continue with treatment for those individuals, because we can get the cholesterol down. There is if this family has heart disease, that's a real risk for the individual, and we can still assess them for PCSK9 on the basis of that's what we thought the diagnosis was, even if there's not that genetic follow-up to confirm it. But on a clinical diagnosis, we can still access those medications, so that's still a benefit in terms of that initial assessment as well. Next slide. And just sort of to wrap up in terms of the advice and guidance, I know sometimes I think when you get advice and guidance back and the patient's maybe not invited to clinic or not listed for clinic, people sometimes say, well, what was the point in that? Is that beneficial? Is that not, have I picked up the wrong patient? I would say no. I think the patients all have high cholesterol. They've all got individual risks. There are a lot of other causes for high cholesterol, not only familial hypercholesterolemia. It may be that there's a secondary cause present. It may be there's a different approach or a different potential cause. And we think obviously there's still a risk here and we can advise in that, but there might not need a lipid clinic follow-up or assessment to actually take that further. We might say that's fine, treat with a statin, get down to such and such a value, 50%, 40% reduction, something like that. But we can say actually from the genetic point of view, there's probably no other test that we would offer this patient. And we can, I guess, sort of put minds at rest from that point of view, although there's probably still a risk for the patient that needs to be managed individually as well. So I would say there are lots of other causes of high cholesterol than FH, and sometimes the focus is very much FH, but we do recognize that other individual risks. We can then recommend next steps. So whether you can use something traditional like Q-risk, or whether straight to treatment might be sensible if Q-risk is going to underestimate the risk in the individual. We may advise around family checking. Sometimes I've another question already about lipoprotein(a), and also kind of wider advice in terms of, I mentioned family testing as well. I would say the other question we get is about patients whose cholesterol historically may not have been above 7.5, but then rises above 7.5. That's something that you can get in later years. We know as individuals age, then cholesterol does rise as you get older. Following the menopause, you do get a sort of stepwise rise in your cholesterol as well. So we do look back at the pattern. I mean, what you would say from FH is your cholesterol is always going to be double what it should be, and that genetic variant would have been present from birth. So the longer we know about high cholesterols, the more solid and weighting it gives the diagnosis. I would say it doesn't always exclude it, because we have been surprised in some individuals. What I would say, certainly, if you are getting above 7.5 and you have got that family history of the first degree relative with high cholesterol, I think that's worth asking advice and guidance for that. We can always say, actually, we think there's a different pattern going on here, or we're not as certain, but I think it's certainly I wouldn't be so black and white as to say it's definitely not or it definitely is, because you sometimes get patients who do slightly rise, although if it's been 3 and 4 in the past and it's suddenly jumped up, you're probably thinking more of a genetic cause. If it's high 6s and then it just goes to 7.5, you might think actually maybe there's something a bit more trying to that could explain that higher average historical value. We can always look at the centiles of how that cholesterol marries up to other people of that age and gender as well. When we look at this data, that's all the advice and guidance has been submitted as well. So I don't think there's an absolute rule for that, but I think the family history and the first degree relative is really important. If you get that, then it's worth submitting advice and guidance to the local clinic. Next slide, please. And I think this final slide, I think this was shared in terms of some of the resources that exist. And I might just sort of hand over to Catherine just to run through some of these just in terms of the final slide.
It was just to give an example of different things that are out there. So if you are interested in reading about this further, there's a really good e-learning on the Royal College of GP website. You don't have to be a GP to access this. You just need to register on the website. But that's a great source of information. The Genomics Education Programme have also got lots of resources on FH. Heart UK is a fantastic resource, both for healthcare professionals and for patient leaflets as well. And then for the pharmacist cohort of people, there's CPPE, which is available, a website also. There's lots of resources on there. So just to share those links for further reading.
Thanks very much. I think that brings us to the end of the formal presentation, Jane.
Okay, thank you, both of you. That was very clear and very helpful. There have been a number of questions in the chat, which you've been doing a sterling time of making responses, both you and Catherine. I think they have all been answered on the whole. There's one that's just come in. If the initial testing shows a total cholesterol more than 7.5, then do we ask them to do fasting lipids straight away? Is there a time frame?
Yeah, Good question. I think we'd put a time frame for if you've got high triglycerides. I think it's like between 5 and 14 days. I think there's no time frame assigned from the cholesterol. So sometimes it might be when the patient can fit it in, and when the when the practice can fit it in to get access to phlebotomy. I wouldn't say from a kind of variability point of view. There's I would probably have that conversation to see if there's anything that you can screen for. Is there anything that's happened recently, change in diet, or anything that could explain it in terms of a kind of a brief sieve? If there's nothing that can explain it, then I think even if you did the fasting one later that week, that's pretty reasonable. If there's something that you might say, oh well, I was away on holiday and I changed my diet or something, I've come back, then you might want to say, look, let's just leave it a number of weeks. If you're changing something significant, say, well, actually, no, I've had a rubbish diet for the last 6 months, I would say you want to leave that a few months, usually about 3 or 4 months, for things to kind of settle down into a pattern. So if you want to make inroads into something, lifestyle changes, 3 or 4 months, I think, is a reasonable period. If there's nothing you can put your finger on, everything's good, then you could go ahead and do it later that week if you want to arrange a fasting then.
Okay, and if somebody does have rubbish lifestyle and rubbish diet and alcohol, and they struggle to make changes, would you still think to follow through, do the fasting lipid sample, and maybe take advice and guidance if this remains an issue? Because not everybody is going to comply, or they'll only be able to partially comply.
Yeah, I think so. I think that would be, I guess it's all degrees of contribution, isn't it, in terms of how much might that contribute versus you've got everyone, the 3 generations of people dying from heart attacks in their 40s. You say, well, actually, no, there might be 2 things at play here in terms of contribution. So I think yes, I think I always go back to family history and say, what is the if there's something pretty fundamental about this autosomal dominant pattern that's jumping out, I say, look, that is really important. And I think submitting an early advice and guidance then is perfectly reasonable. If you think family history is a little bit vague, or we're not so sure about that, and there's the something to modify, that then giving it a bit longer in that circumstance seems reasonable.
Okay, last couple of questions in the chat. Not quite FH related, but ApoB, and when that's raised, requested when the triglycerides were raised, does this change how we treat a patient? Would we still go by Q score and start statin when greater than 10%?
This is a whole new presentation, actually, the hypertriglyceridemia pathway. Absolutely. So I think this is referring to the recommendation in Neely about checking apolipoprotein B when you get a raised triglyceride in that yellow section of the Neely guidelines. So what we're really trying to identify there, it's low apolipoprotein B, so below 1. It is a trigger to refer to the lipid clinic, and there's a specific condition that we look for, called type 3 hyperlipidemia, again, in a genetic condition, which can be not exactly screened for, but one of the potential markers is a lower apolipoprotein B. That if that was low, then you should be seeking advice and guidance from the lipid clinic. In terms of treating, you're probably going down a line of a fibrate in that case. I would probably refer back to the yellow hypertriglyceridemia section, depending on how high the triglyceride was. So I think there's a few different options on that one. I'm happy maybe to take that one offline if there's a bit more detail on that one, but it depends. I wouldn't say it's straightforward as a Q risk and a statin. It kind of depends on the triglyceride after that. So I'm happy to pop an email address in the chat or something if someone wants to get back.
Okay, and one last one, because we're slightly over. Claire's an optometrist, and the optometrist ask about family history. If they find that patients have a significant family history of premature coronary disease, would they refer to the GP, or is there a direct referral to yourselves, i.e. the lipid clinic?
So as an optometrist, we have had patients who've come sort of through this route, but I think the key thing is we get referrals via the advice and guidance choose and book portal, and patients should have a have a cholesterol checked. So you may have ocular changes, but maybe not quite have a cholesterol that is, well, maybe a different pattern of dyslipidemia where they got high triglycerides versus high cholesterol. So I think knowing the phenotype of the lipids is important. So I would say that it's probably via primary care, I think, would be where we get the referrals. But we've got people who have maybe been referred from their ophthalmologist or optometrist or their vision check, and then they come in via primary care. So that's probably the route we would expect to come, maybe rather direct from the optometrist.
Yeah. And actually they might need treatment whilst they're waiting to go to the lipid clinic as well as the secondary causes. So that sounds very sensible. And I am going to stop it after this, but if somebody has a rubbish diet and they're waiting the 3 to 4 months to get their lipids repeated, do you give them a statin in the meantime?
So do you give them a statin in the meantime? So I think there's, again, I would say generally no. I'd say if there's something that you think that can be changed, if it's primary prevention, I guess it's looking at the individual's risk, I suppose, in terms of its primary prevention, and you've got substantial things to change. I would always encourage them to make the changes. What I wouldn't always say is that it's like a sticking plaster, isn't it? Or like it's like a seatbelt. The statin is a bit like putting a seatbelt on in your car. It gives you some risk reduction, but you could still be driving at 90 miles an hour, and there's still other risks as well. So I think I would always try and make as much lifestyle kind of impact over that 3 or 4 months before reassessing, unless potentially there was a secondary prevention case or something, obviously, where you would be looking to kind of lower acute risk more quickly.
Okay, thank you very much indeed. Thank you, everybody, and thank you to Stuart and to Catherine for such an excellent presentation and their sterling work at dealing with the questions as they came through the chat. So thank you again, and thank you everybody for participation. Do please give us feedback to help us look at further events. Goodbye.